Hello, good evening, friends. Today I thought let me take a very pure theory topic because it is very important for you to write answer in a recent advanced paper. I saw this in one of the question papers recently. I had gone as an external examiner, and this was a question which was not answered that well by the students. So I thought I must talk about this. Fibroids are such common problems and probably the commonest indication for abdominal hysterectomy. So when that being the case, we must know a little bit more about fibroids, why fibroids occur. In fact, most of the patients are not able to understand why I should get a fibroid. And PGs also cannot write beyond few sentences in the exam. I have got more than 45 slides to write a very good answer so that you get full marks in this question. May I request all the postgraduates to keep taking screenshots of this if you want, because I may take some time to upload this on the YouTube. You may share with your friends also if you want. Well, let's go without wasting time because lots to cover. I would be covering under following headings: risk factors, theories, genetics and extracellular matrix, miRNA, hormones, growth factors, cytokines, and finally fibromatosis. Let's take up one by one. First, the risk factors. All of us know about the risk factors, but I'm going to talk in detail about each risk factor. That's how you have to write answer in the exams. First of all, hormones. Everybody knows that it is because of hyperestrogenic status. But recently, we have understood that even progesterone can stimulate the growth of fibroids. That's why anti-progesterones have been used. Other day, when I took the class on management of fibroids, I was talking about mifepristone and ulipristal. The effects of estrogen and progesterone levels and their metabolisms is definitely there, but some have questioned it. Why? They are demonstrated that fibroids within the same woman often have different growth rates despite having a similar hormonal milieu. Now we can understand one lady having hyperestrogenic state, other lady is not having hyperestrogenic state. So this lady is going to have fibroids. But what this particular sentence says is that in spite of having the same hyperestrogenic state, the growth rate is different in a given woman. So is it only hormones, estrogen or progesterone, or is there something else? That is why it is being questioned. Each tumor appears to have its own intrinsic growth rate. Each tumor, all of you know that fibroids are multi-centric in origin. Multiple fibroids will be there, but each one of them have got its own growth potential, maybe depending upon the site, maybe depending upon their other characteristics, location, and the starting size. Their growth appeared not to be influenced by tumor characteristics such as size and location. So it is something else that is probably guiding them. The next one, all of us know about the race as a risk factor. These are all undergraduate factors that if they just mention hormone, race, family, and this and that, that's enough for them. But for postgraduates, it is not enough. You have to explain everything. Race the cause of higher prevalence among Black race is unclear. So we know that it is more in Black race, but why it is so, it is unclear. Molecular markers also differ between tumors from Black and whites. Probably there is some different molecules that are acting in Black and in white. They are different. Differences in estrogen levels have also been found. Maybe they have got little more estrogen, the Black race, others may be having less estrogen. But still unclear whether these differences are genetic or due to known variations in hormone metabolism based on the race, or environmental factors, or diet. Of course, the last two can be addressed because now Black people are there even in all the countries, not only in Africa. So it may not be environment, but maybe diet, because wherever they go, whether they're in America or in UK, they may be having the similar diet. So, but we don't know at this stage. But it is sure that Black race have got more incidence of fibroid. Then comes ethnicity. Race is something, ethnicity is different. Fibroids are monoclonal in origin with variable molecular characteristics determining tumor size and growth. These are due to ethnic differences. So again, there are different markers in different ethnicities in expression of the dysregulated protein in uterine leomyomate. So there has to be a dysregulation of the proteins. That's why every lady has got myometrium, isn't it? But every lady will not have myoma. There is some dysregulation of the proteins, which leads to formation of myoma. So that is based on the ethnic differences, maybe. This is again one of the theories. Then comes the most popular theory, that is genes and family history. All of us know the family history has got such strong connection with the fibroids especially. It is also interesting that myomas and keloids are more common in Black women and have similar gene characteristics. So there are certain women who have tendency to develop keloids. We do surgery for everybody. Most of them will have beautiful scars, but some of them will develop keloids. That is genetically connected. And maybe such people have got genetics connecting to myomas. Furthermore, it is well known that family history could represent a strong predisposing factor. That is, first degree relatives of affected women have a 2.5 times increased risk of developing fibroids compared to second degree relatives. What do you mean by first degree relative? Mother or sister compared to aunt or somebody else. They are the second degree relatives. So first degree relatives have got 2.5 times increased risk of developing fibroids. So it is not linear, it's not uniform. The next thing is age, BMI, and fat. Of course, we all know how fat and BMI can affect. We know that there is peripheral conversion of androgens into estrogens in women with obesity. That's where, again, they may have higher estrogenic levels. As age advances, also, the estrogen increases. That's why very young girls, the fibroids are not that common, but in the middle-age, fibroids are common. Rapid increase in incidence after the age of 30 could be the result of time-related hormonal changes. As I just now told you, in younger girls, adolescents, the estrogen is not so much compared to middle age. Of course, later in life, after menopause, it comes down. That's why fibroids also shrink after that. Or an enhanced symptomatology from existing fibroids. So what happens in these women, the fibroids may have been there, but as the age advances, one thing is they grow also, and then the symptomatology also increases from the existing fibroids. Risk of myomas increased 21% with each 10 kg increase in body weight and with increasing BMI. So it makes sense to actually maintain a good weight or a healthy weight, what I would say. Because with each 10 kg increase, there's a 21% increased risk of developing fibroid. So everything is interconnected in life. Also, in women with greater than 30% body fat. So if they have more of body fat compared to muscle mass and bone mass and other things, those are the women who would develop fibroid. The next is inflammation. In fact, I teach undergraduate students that there are only 4 problems in gynecology, and there are only 4 symptoms in gynecology, and there are only 4 problems on earth. I will teach some other day. It is so easy. There's nothing more. And one of them is inflammation. You take any disease now, whether it is asthma, diabetes, fibroids, you take any disease, it is all explained through inflammation. So that is the most important thing. Okay, let me not give you, let me not keep a suspense. Let me tell you what are the 4 things that I always teach. There can be a congenital problem. There can be an acquired problem. Acquired is usually inflammation. Now, inflammation in turn can be due to so many reasons, including infection. So I'm not going to talk separately. Number 3 is neoplasia. Neoplasia can be benign or malignant. And then, of course, number 4 is when you rule out all of them, then it is functional problem. Of course, if you want to add 5th one, it will be accidents and trauma, which is totally different. But in obstetric or gynecological scenario, accident, I usually take it as pregnancy-related problems. After all, pregnancy also can be due to accidents, isn't it? That is a joke. So co-culture of adipocytes and uterine leiomyoma cells result in an increased proliferation of leiomyoma cells. See that, the effect of inflammation. Obesity-related chronic inflammation and initiation, as well as the progression of uterine leiomyoma. Obesity somehow is not good at all. We all know that. But how does it harm us? This is the way. It creates an inflammatory condition, chronic inflammation. Those who are obese, there is a chronic inflammation going on in the body. And when these adipocytes and uterine leiomas are co-cultured, you could see that an increase in proliferation of leiomyoma cells. That means when these muscle cells are making friendship with fat cells, they also, like fat, they also grow. And that's why they become fibroids. In a simple way, if I have to teach. TNF alpha treatment, now to make it complicated, you throw some nice high sounding words in the answer sheet. So the examiner gets scared and he'll give you more marks. TNF alpha treatment increases human uterine leiomyoma cells proliferation in a concentration dependent manner. It means the same thing. These are all inflammatory markers, isn't it? TNF alpha. So TNF alpha treatment increases human uterine leiomyoma cell proliferation in a concentration dependent manner. The more inflammation, the more growth of the leiomyoma. So this is very important. Even in diabetes, you need to explain. There was a question on, short note on inflammatory etiology of diabetes. Many students have left that question. They had not heard of it at all. But let me tell you today, every single disease can be connected to inflammation. Inflammation does not mean infection. I hope all of you know that. Then comes the risk factors of diet and exercise. It is not clear whether diet habits such as consuming red meat, ham, green vegetables, or fiber could influence the growth of myomas. See, in the other slide, we said the increase in fibroids in black race may be related to their diet habit, but this particular slide is contradicting that. Of course, life is full of contradictions. Science is like that. Science does not mean that it is the ultimate truth. Science is seeking truth. That's the beauty of science. Science never says, I know everything. That is the difference between dogmatic, other field and the scientific field. Science always says, I don't know. And that is very important in life. The day you say, I don't know, will you explore why, what, when, and other things. So please, we must have this humility of saying, I don't know. Then only we will know. It is also difficult to analyze the specific effects of physical exercise on development of uterine myomas. See, everybody says do diet and exercise, and it has got a lot of benefits. No doubt it has got a lot of benefits, but how exactly it works is not very clearly understood, as far as fibroids at least. Vitamin D, no talk these days can be complete without talking about vitamin D. And vitamin D has become like one panacea for everything. There's an inverse correlation between serum 25-hydroxy vitamin D levels and fibroid prevalence in Black subjects. Again, most of these studies probably are done in Black subjects because the incidence is more in them. Pathogenesis of fibroids seems to involve a positive feedback loop between extracellular matrix production and cell proliferation, and vitamin D might act to block the positive feedback. So if vitamin D is not there, then the positive feedback loop will be activated and there will be production of extracellular matrix and there will be cell proliferation. Cell proliferation means what? Newer growth. Of course, luckily it is benign growth here, and that's why we will get fiber. So vitamin D is very important. Go to sun. Sun is, that's why probably sun is worshipped, but you need to at least go to the sun. If not, pray to the sun. Go in the sun in the afternoons. It's better. You'll get vitamin D free of cost. Risk factors, that is Menarche and parity. All of us know, lower the parity, fibroids. In fact, some textbooks beautifully mention that the virtue of being unmarried or being not having any children is that you will get fibroids. That's the gift that you get. So low parity is a known cause of, or if there is a last childbirth is very far away, then you say there's a possibility of fibroids. Menarche also, like that means earlier the menarche, the longer duration of estrogens. So that's how it is. Early menarche before the age of 10 is a risk factor, obviously, because she will start producing estrogen like anything. And that's why if they mature early or they have menarche early, they will also become short-statured because estrogen comes very early and they will close the epiphysis, isn't it? While a menarche after 16 seems to decrease the risk, lower incidence and a reduced number of clinically apparent myomas are linked to increased parity due to a remodeling process of the extracellular matrix and a specific expression of receptors for peptide and steroid hormones induced by pregnancy and parturition. So now we know why the more children, less fibroid. That is because of these things. The expression of receptors for peptide and steroid hormones induced by pregnancy parturition will have a remodeling process of the extracellular matrix. So that is why fibroids are less, the more children have. See, you don't know where to do the balance. If you have more children, you will have less fibroids, but more children means other problems. There could be prolapse later, or there could be more sexual activity right from the beginning will cause, cancer cervix. You don't know where is the balance. Of course, you have to have a balance in life. Then risk of MHT. What do you mean by MHT? Menopausal hormone therapy. That is the new name. It's not not brand new name. It's been there, but we have been used to calling it HRT. HRT simply means hormone replacement therapy. That may be done even in a younger age group also, isn't it? In case of especially Turner syndrome, you may give hormone replacement therapy. So MHT specifically means menopausal hormone therapy and COC, the combined oral contraceptive pills. Whether they will increase the fibroids, let's see. MHT does not to be responsible for any important stimulus of fibroid growth. Okay, thank God. Conflicting data coexist about relationship between COC and growth of leiomyomas. But theoretically, it is possible, isn't it? It has got estrogen, that way a synthetic estrogen, ethinyl estradiol, is more potent and strong than the natural estradiol. And now we know that progesterones also can influence the fibroids. So, but there's conflicting data. This could be related to differing content of estrogens and the type of progesterone in each specific OC preparation. For everything, there is a reason that is given in gray color. Smoking. What do you say? Smoking is not good at all for anything in life. That's what I say, no? And I jokingly say that smoking, only good thing about smoking is you can lose weight one lung at a time. My standard old joke. It has become like now poor joke maybe. Let's see what smoking does to fibroid. My God, smoking may reduce the incidence of myomas, but now the choice is whether to die of smoke, what do you call, fibroids, or whether to die of lung cancer. Okay, so we can decide. I'm trying to underline this. No, don't start smoking now because it will reduce the fibroids. Nicotine inhibits aromatase and reduces the conversion of androgens to estrogen. That is the reason. Okay, so somehow estrogen has to come down, but don't smoke for that reason. Smoking also exerts a powerful inducing effect on the 2-hydroxylation pathway of estriol metabolism, which is likely to lead to decreased bioavailability of estrogen target tissues. Of course, whatever it is, finally, the truth is it has to act through estrogen and progesterone. So if you reduce the estrogen somehow by reducing the weight, reducing the BMI, and having healthy food and all that, but smoking is not advisable just to reduce the fibroids. Now I go to the theories of pathogenesis of fibroids. Looks like it is going into the maybe going to second class, but doesn't matter. We need to understand all these things. What are the theories? Increased levels of estrogens and progesterone, I'm repeating, could result in an augmentation of mitotic rate that could be responsible for somatic mutation. Okay, so this is very carefully we have to understand this. Estrogen and progesterone are there in every lady, right? But that would induce a somatic mutation in genetically predisposed women maybe, and that's why there is augmentation of mitotic rate in certain ladies. Increased concentration of receptors for estrogen, ER what we call, in certain regions of the non-neoplastic myometrium of the uterus myomatous. So that is why, even though estrogen is there in every single lady, but everybody will not have, there should be increased concentration of receptors of estrogen in certain regions of non-neoplastic myometrium. So then there will be fibroid. Pathogenesis might be similar to a response to injury, inflammation. What is the response to injury? Inflammatory response, isn't it? Whenever there is an injury. Ischemic damage linked to release of increased vasoconstrictive substances at the time of the menses. So this is a response that you can see during inflammation, but it is happening naturally here. I'll repeat, ischemic damage linked to release of increased vasoconstrictive substances at the time of menses. So body response when the menses start is to stop the menses. And there are several mechanisms. I'll take another day DUB class. Now there is nothing like DUB. In the olden days, there used to be a chapter called DUB, and it used to be my most favorite chapter. There are 5 to 6 mechanisms why menses stop, thank God. Otherwise, the day you attain menarche, everybody would die, isn't it, of bleeding. So vasoconstrictive substances are released as one of the mechanisms of stopping the menses, and that is an inflammatory response, and that is one of the theories for fibroid. Smooth muscle cells of the myometrium could react to injury with the synthesis of extracellular fibrous matrix. Somehow there has to be synthesis or proliferation or multiplication of this extracellular fibrous matrix. So smooth muscle cells of the myometrium could react to any sort of injury. Now here injury is somewhat like menses itself is posing as an injury. After vascular damage, basic fibroblast growth factors are overexpressed in leiomyomas. Probably, even vascular damage due to any other reason also, maybe even cases of endometriosis and other things, or even surgeries that you do on the uterus, that could lead to some sort of vascular damage, and there will be overexpression of the fibroblast growth factors, and that may lead to myoma. These are all theories. I am not saying these are all proven, but these are all theories. Fine. Let's now go to the next aspect, genetics and extracellular matrix. I kept on talking about extracellular matrix, extracellular matrix. What is this? Let's see. Before that, genetics. About 40% of uterine fibroids are chromosomally altered and bear cytogenetic anomalies shared by several other types of tumors. So we all know most of the tumors have genetic origin, isn't it? Genetics is not final. You may be carrying the genetics, but there has to be environmental factors and other habits and everything. So like everybody who is having the genes for diabetes will not have diabetes. Just because both parents have diabetes, not all children will have diabetes, isn't it? Similarly, about 40% of uterine fibroids are chromosomally altered and bear cytogenetic anomalies shared by several other types of tumors. Translocations between chromosomes 6 and 10, 12 and 14, trisomy 12, and deletions of chromosomes 3 and 7. We can't remember all these things. Impossible to remember. Anyway, for PGs, no choice. On the day of the exam, you have to just quickly go through this. My daughter had a habit of writing some of these kind of things which cannot be remembered at all, and she didn't want to remember actually. But on the day of examination, she would have written on it in a separate diary. What are the things that has to be read on the morning of the exams? On the day of the morning, she will not read anything else. She would just read these kind of factual things. Then HMGA2 gene was found in translocation 12 to 14. All the best. I mean, I don't have to remember this. Expressed in uterine leiomyoma and in other human tissues with a proliferative phenotype, fetal tissues, lung tissues, and kidneys, but not in the normal myometry. So that is the genetic problem that we have for fibroids. Heritable cancer syndromes can be characterized by uterine leiomamas such as hereditary leiomyomatosis and renal cell cancer. Those who are supposed to get renal cell cancer or leiomyomatosis also can develop fibroids as a benign counterpart of them. So heritable cancer syndromes, they need not always have cancer. They can, before cancer, they may have a benign tumor like fibroids. This syndrome predisposes patients to benign leiomyomas of skin, not just uterus, and early onset of renal cell carcinoma. That's a tragedy. Also, we have seen, other day I was talking about in one of the lectures, that if you have somehow this oncogene, even if you remove ovaries, I was doing the debate, I think now I remember. In the debate, I was telling a person who has got BRCA1 and BRCA2, you may remove ovaries to prevent ovarian cancer, but unfortunately, these women can develop, in spite of removal of ovaries, they can develop what is called ovarian-like cancer of the peritoneum because they have that gene. Similarly, here also, when you have that particular oncogene or whatever heritable cancer syndromes, you can have collateral problems like, you can have first as a tumor of skin, tumor of uterus, and finally they may land up in renal cell carcinoma. You remove the kidneys, they may develop cancer somewhere else. I told you also one of our, faculty here had 10 years ago cancer of the tongue that was taken care of, but 10 years later, that person developed renal cell carcinoma. So these are the things. So we have to be vigilant all the time. Fumarate hydratase is the gene implied. Please remember that, okay? It encodes a Krebs cycle enzyme responsible for conversion of fumarate to malate. I'm just reading out. I don't intend to remember this. Alport syndrome is an X-linked progressive nephropathy associated with leiomyomas due to defect in COL4A5 and COL4A6 genes. These are all of interest to researchers and to impress in the exam to write something like that. You can write COL3 also, no examiner will know about it. Maybe 4 or 5, or you can just scribble it. That's the technique of some of the average students. They just scribble it so that nobody can read it. I'm not misguiding you. Sorry, I was joking. Chromosome 10q24.33 is best associated with leiomyomas, and the region was mapped to 5 region of the SLK gene encoding STE20 like kinase. Take a screenshot. Extracellular matrix component. Now, extracellular disorganized matrix is a peculiar characteristic of fibroid growth. There has to be some disorganization. If it is an organized way of growth, then there will be normal uterus, isn't it? Mainly consisting of collagen subtypes, fibronectin, and proteoglycans. Recently, more collagen subtypes such as COLA-A1, 4A2, 6A1, 6A2, 7A1, and 16A1 have been found expressed to a greater extent in leiomyoma cells compared to myometrial cells. When you want to score more than 90% marks, write all this. Matrix metalloproteinases, that is important, MMPs, have also been implicated in leiomyoma remodeling. MMP1 is expressed more in leiomyomas, while MMP2 is less expressed. This you can write, but don't remember all other things. That's why I gray out. What is not very important, I gray out in my slide. By now you have understood that. Mechanical transduction. Mechanical properties of leiomyomas are a key feature of these tumors and may contribute to their growth. Mechanical factors. That is beta-3 subunit of transforming growth factor, TGF beta-3, and its signal mediators are overexpressed in leiomyomatous compared to normal myometrium. And mRNA expression of multiple ECM genes in uterine leiomyomas is decreased when the TGF beta pathway is downregulated. All going above our head. PGs must be thinking, what a lecture. Sir, you could have taken a different lecture, but believe me, this is important for you. Finally, I am coming to miRNA rather, hormones, growth factors, and cytokines. So microRNA, miRNA means microRNA, are a novel class of small non-protein coding RNAs, which regulate a high number of biological processes by targeting mRNAs, messenger RNAs, not microRNA. MicroRNA means miRNA. mRNA means messenger RNA for cleavage of translational repression. Several miRNAs such as LET7, MIR21, MIR93 are significantly dysregulated in uterine leiomyoma compared to those in normal myometry. So just write microRNA will have dysregulation of the non-protein coding RNAs. That's why there is haphazard growth. MicroRNA epigenetic changes have also been implicated in leiomyoma formation. What is epigenetics? I've been telling epigenetics. So let me quickly tell you what is that. It is nothing but study of how behavior and environment can cause changes that affect the way our genes work. So that's why I told you, not just the genes, our behavior, our environment, that's why everything is important in life. Meditation, keeping yourself cool, calm, and everything. So drive away the problems. Epigenetic abnormalities in fibroids, abnormally hypomethylated ER alpha. Follow-up studies demonstrated globally abnormal genomic methylation in leiomyomas compared to myometry. Further research will need to identify specific gene responsible for development of leiomyomas that can be directly targeted as preventive therapy. See why they are doing so much of microRNA and all these things. The scientists are so wonderful people. They want to go to the root of it. We gynecologists and surgeons want to remove fibroid and make money. But they are trying to think of treatment which can prevent fibroid, which can tackle fibroid. That is the beauty. Hats off to them. Estrogens, uterine leiomyoma growth is strictly related to estrogens and their receptors, mRNA and protein expression levels, as well as the content of ER, that is estrogen receptor alpha and estrogen receptor beta, are higher in leiomyoma compared to those in normal myometrium. May exert their growth stimulatory effect on leiomyomas immediately by cytokines, growth factors, and apoptosis factors. Can maintain progesterone receptors. That is the beauty. Estrogen helps maintaining progesterone receptor levels, and thus progesterone through its receptor may promote leiomyomas. They are friends. They are, after all, brother and sister. Estrogen and progesterone are maybe sisters or brother and sister or brothers or whatever you say. They help each other. May stimulate leiomyoma growth partially by suppressing normal p53 functions. Progesterone interacts with its receptor PRA and PRB, something like what we said, alpha and beta there, playing a key role in myometrial and leiomyoma biologies. Also interacts with some growth factors. It upregulates the EGF, mitogenic, and TGF, beta-3 biomodal action expression. We heard of this TGF in the previous slide. PR content and miRNA levels are microRNA, okay, not messenger RNA, are higher in leiomyomata than those in normal myometrium. Progesterone significantly introduces LAT2 mRNA levels, which is blocked by co-treatment with PR antagonist mifepristone. That's why mifepristone is used as a treatment. But how much it works, I'm not very sure. Growth factors, of course, several growth factors and their respective receptors have been demonstrated to play a role in leiomyoma growth. A whole lot of them. VGEF is the notorious one, EGF, HBEGF, whole lot of TGF series are involved. Other growth, recently, activin and myostatin have been identified in the myometrium and in leiomyoma. Activin A myostatin could regulate myometrial cell proliferation, and parathyroid hormone-related peptide are also implicated in myometrial biology. Cytokines and chemokines, we know many cytokines have been implicated. Even chemokines and receptors have been shown to be mediators of above-mentioned processes. In experimental systems, increasing carcinogen exposure tends to increase the number of tumors in their degree of malignancy. Low carcinogen exposure tends to produce benign neoplasms, whereas high exposure tends to produce both malignancies and higher number of tumors. Finally, fibromatosis is nothing but endometrial, subendometrial myometrium unit disruption disease. Should be considered a new entity and distinguished from adenomyosis. This condition is expressed mainly by a pathological thickening and abnormality of the subendometrial myometrium, that is the possible set of origin of submucosal and intramural fibers. So it's confusing with adenomyosis. There also we see that, but this is a different entity. So sum and substance, the etiology of uterine fibroids remain unclear, multifactorial, enigmatic. Classic studies showed that steroid dependence of myomas of growth and development. The genetic background seems to play an important role, and cytogenic anomalies observed in about 40% of uterine fibroids. Abnormal ECM expression, growth factors, cytokines, chemokines, all are important. And endometrial, subendometrial myometrium unit disruption disease, expressed by a pathological thickening or abnormality of subendometrial myometrium, may be the possible set of origin of submucosal and intramural fibroids. Endometriosis, not endometriosis. This is a different issue. Thank you very much for your patient listening. I don't know how much you can remember about this, doesn't matter, but main theories you all know.